Thank you so much for having me today. I only wish my mom were here. Thanks, that was very generous, Larry. And the work that you do is so important. I must say, David kind of sucked the oxygen out of the room when you think about the implications of some of the budget issues that we're talking about. By the way, the last time I received such a gracious introduction was at the Gwendolyn Brooks Academy. I spoke to the junior class. It's a wonderful high school in the far south side of Chicago. Has anyone ever been there? It's a wonderful facility. It got some attention because some parents at the Peyton School were afraid to go there for a baseball game, and it was canceled. And I actually understand why they were afraid, because when I went there, it has this beautiful bucolic campus, and there was this group of geese that were sort of looking at me. It was really scary. I was introduced by the assistant principal, and she gave a really long introduction that was basically from the University of Chicago Pravda faculty profiles, and it was reading all the journals that I had published in, and I had a grant from the National Institutes on Drug Abuse and so on. And I was thinking, like, these juniors in high school, like, what could possibly be more boring than my reader? And it actually turned out that it was the opposite. That the kids, I gave a talk about crime in Chicago, and all the kids were asking questions, I was a Princeton undergraduate, and they're like, what was it like to go away to school at Princeton, to be in this place, that we sort of heard of? And they were so engaged that I sat on the stage, and there were about 100 kids, and you could have heard a pin drop. And it turned out that kids are so interested in so many things, and we sell them short when we expect them to be, the most annoying aspects of adolescence, as if that's all they are. And so it was a really special moment for me going around the city. And this is a special moment because I do think that Voices is such an essential pillar of the coalition that pushes for not only humane policy, but also humane policy that's evidence-based and that shows a kind of sophistication and credibility about the numbers, so that if I get something from Larry, I can learn about what's happening in the state, and I don't have to worry, well, this is how has he shaded the number? Most advocacy groups, when you sort of get the email that warns you about something, okay, how do I read past whatever they just told me to figure out what's really going on? And you have such credibility that comes from the integrity of the work that you do. And there's no organization quite like it. So it's an honor to be here. I should say that I come in multiple guises here today. I'm a public health services researcher. I'm a media commentator. I actually made my own campaign commercial. I'm very proud of that because Chris Hayes called it the best campaign ad of 2012. I should tell you that it was not the most widely viewed campaign. But one of the great compliments was someone attacked it and claimed, it cost me $500 to make it. And I had someone claiming that there was some undercover advocacy group that had somehow helped me make it because it was just too good. So I took that as a great compliment. If you become the object of conspiracy theories, you're doing something right. I'm an advocate for what became the Affordable Care Act. And I'm also a family caregiver for an adult with intellectual disabilities. And my wife Veronica and I are so very grateful for the state and federal programs that help us, help my brother-in-law Vincent every day. And I research so many topics where we don't see the A game of American social policy. And intellectual disability is really one where you really see our society coming to play and doing our best. And my mother-in-law died suddenly, and her son lived in upstate New York, and we had to put him in our van and drive him to our house. And suddenly he was living in our bedroom, and he was 38 years old and weighed 340 pounds, had multiple medical problems, was severed from all of the services he had received in New York State, and suddenly we had to figure out how to get him into the Medicaid system in Illinois and how to find a workshop for him to go during the day and all those other practical things. And I was very scared at the time of what that would be like. And there certainly were many difficult moments But it has not been a sad and depressing experience or a scary experience. One of the reasons why it has not been is that everyone that's dealt with us, I would say 100% of people have been unbelievably nice and supportive, and we've benefited from in so many ways from so many people. Just walking around in the street, the kids who are standing out on the corner, they'll wave, they'll say, everybody's got a cousin, a sister or a brother, and I'm now writing a book about intellectual disability policy as a quiet success in America. And despite many challenges and failures, and I'll talk about some of them, I think it's important to notice this is a really overlooked triumph in America. And in so many ways, our nation and even our state, which is not always a leader in this area, has opened its heart and opened its wallet to some people who need help. And millions of people around us are living more dignified, productive lives because of that. And it's at least worth taking a moment to note that. So, you'll have to excuse me, I'll have to walk around a little bit because there's a micro dot on the computer that has my slide. So if you think about all the different ways that we have, can you hear me?
Yeah.
Can you hear me over there?
Yes.
So there are many different ways that we have embraced people living with disabilities, and it's worth thinking about it because so many of the issues on this table are actually bar charts that were pointing down in David's presentation, in programs that are being cut in various ways. But one is improved physical access in daily life. It's amazing how much progress has been made there, partly through the Americans with Disabilities Act. IDEA, the whole network of IEPs and other services that so many Illinois children need. The Olmstead decision, which is probably the most famous, probably the most important Supreme Court decision none of my students have ever heard of. But everyone in Illinois public policy knows a lot about Olmstead because the state is being sued in so many different flavors and ways to try to reduce our emphasis on institutional care for people living with disabilities. And the Olmstead decision gives people a legal right to be in the least restrictive environment that is appropriate for them. The deinstitutionalization efforts from the 1960s to the present. Deinstitutionalization is kind of a dirty word. Among a lot of people in social policy, it conjures up images of homeless, mentally ill people on the street who have been neglected, and that's a part of the story, but it's only a part of the story. And certainly for the intellectually disabled, there are millions and millions of people who are living on a human scale in their own communities as a result of the policies that are implemented. Income security through SSI and SSDI. And also changes in popular culture, which should not ever be discounted. One of the amazing things about intellectual and developmental disabilities is the way that our popular culture has completely changed the way that we think about it. And if you look in the upper left corner, we have the show Life Goes On. Probably some of you are too young to remember that. It's one of the staffiest shows, but I liked it. Parenthood, and in the lower left, you see there's a young couple, both of whom live with Down syndrome, who are now married. And that is, I forget what the America's Got Talent or some show like that I've never watched is in the middle. And even L.A. Law had a character as well. And I should say all of these individuals who are living with intellectual disabilities in these pop culture images, they tend to be either children or very childlike. And actually one of the challenges that we have as caregivers and as individuals living with disabilities is that people aren't always childlike. My brother-in-law is very interested in going and visiting the house of our pretty neighbor who lives nearby. And, and he's a man. And that's okay. And, he's not a child. And we have to embrace that and not be scared of that. So one of the things I should say, I contribute a column to the Washington Post Wonk blog section, and I have the privilege of interviewing some amazing people, many of whom live with profound economic or health challenges. And as part of my book, I'm trying to convey to people the wide variety of circumstances that people living with disabilities are experiencing. There's no such thing as the disabled. That's such a huge heterogeneous population of people with different challenges. the major policy challenge we face in that area is that in actual human life, disability is a multi-dimensional and continuous concept. And you know, if you have asthma and you're working as a policy analyst in Chicago, you're really not disabled. But if you have asthma and you live in Wheeling, West Virginia, and the local economy requires that you be able to work as a coal miner, maybe you are disabled in terms of your functional interaction with the environment. And public policies are always trying to take this multi-dimensional, continuous human reality and jam it into a 0-1 binary administrative decision. That's hard to do, especially when you have millions of people and you kind of can't stop and run an OJ trial on every person who comes through the door. So one of the ways that I'm trying to convey this is by going and talking to people and showing their individual challenges and opportunities. And so and many of these people I refer to as my real-life Madden team, those of you who are football fans, because some of these people are just so amazing. This family that I have up on the screen is, the young woman in the middle is 27 years old, and her name is Beth Terrell, and she lives in Elmhurst. And in part because of major changes in public policy, she has an amazing life. She has an intellectual disability. I met her through her parents, Kathy Vicker Terrell and David Terrell, who are both active in intellectual disability work. And I'm sometimes a little bit reluctant to tell Beth's story because for so many others it's a life that's kind of out of reach. So I want to say results not typical, so it's stamped on this. And it speaks in part to the disparities because her family is in a position to help her in ways that not every family in Illinois can. But she gets up every day. She drives herself to work, and she drives herself home to her apartment. She works at Hinsdale High School in food preparation. When she's not working, she hangs out with her boyfriend Chris, and she plays competitive volleyball, and she swims, and she can bench press 200 pounds. And she does odd jobs around her parents' home, and she's just a very productive member of her community because she's received a variety of supports that allowed her to live as full a life as she's capable of living. Here's another man I follow on Twitter. This is Joe Entwistle, and his Twitter handle is Wheelie Boy. Joe is on SSI, and Joe's on Medicaid. And you might assume from that all sorts of things about his life. What you probably would not assume is that he is a very successful health policy analyst around town here. He lives in the south suburbs of Milwaukee, and he commutes on the train, and he takes his $45,000 sip and puff wheelchair about a mile from the train station to his office every day. Someone comes to his house at 4:30 in the morning and helps him get dressed and prepared for work. And we think of programs like SSI as traps that create disincentives to work and that contribute to all sorts of behavioral pathologies in American society. And in fact, many of these programs contain much more sensible and humane and wise provisions to help people get into the workforce when people are able to use them. Joe is he's a C4-5 quadriplegic from a wrestling accident when he was 16 years old. Now I should say that not everything about our social assistance system is so terrific. And one of the things that has been striking to me in the debate over health reform is a lot of the people who are against universal coverage are noting that there are some problems with Medicaid. And I must say, as a caregiver, it reminds me a little bit of this term mansplaining. Any of the women here hear the expression mansplaining before? That's when a man explains to a woman in an authoritative and pompous way something that a woman actually knows more about than he does. And some of these topics include things like a man explaining the realities of menstruation to women, pregnancy, My favorite example of mansplaining was in college when a young man was very patiently and somewhat pompously explaining to this 30-something woman a physics problem. She was at the time his physics professor. So, did you know that if you're on Medicaid that there are certain specialists that you can't see, that you'd like to see? That people in hospitals are not always as polite to the people on public assistance as they should be. Most people who actually live with Medicaid every day, we kind of know that. We've experienced it. We've been sent down to the hospital pharmacy and then been told that the pharmacy doesn't take Medicaid. Or we've called the specialist and not gotten the call back. That's part of the reality of Medicaid, and it's something that Voices and others have worked hard to try to improve. Another thing that I find so difficult about this mansplaining conversation among those who are opposing expanding Medicaid is when we go down to Springfield and try to argue to improve Medicaid, are there some people going to be there and help us when we're trying to get more money to improve the program, to raise provider reimbursements, or to do the other things that we need to do to make Medicaid better? Many of these same people will be on to the next talking point, and they won't be there to help us. Many of Medicaid's problems reflect the fact that the program needs more money. And there's a rhetoric of fiscal crisis around Medicaid that makes it harder for us to run a humane and efficient program. I must say that the biggest fault in Medicaid, which came up in the earlier presentation, shows up whenever I meet anybody who has a serious problem or who's in a severely vulnerable population, whether they're homeless or they have a mental illness or they've been through the correctional system. And this problem is as apparent as the smile on their face. I wish that we could provide the kind of dental care to people on Medicaid that people deserve, and we just have not. When Illinois Medicaid stopped covering dental care officially, except for basic extraction, at that point I hardly noticed because we had given up on actually using the program to get medical care for my brother-in-law long before that. I did a story in the Washington Post where I went to one of the Heartland clinics and I just talked to patients in the waiting room. And here's two of them. Robert on the left told me that he won't chew on his right side for about 2 years. He hasn't been able to really chew on his right side. He said it's painful and the teeth are weak. And he needs a root canal, which would cost about $1,000, and he doesn't have that $1,000. And in fact, he needs a tooth cleaning, which costs about $50. He doesn't really have the $50 for the tooth cleaning either. And the young lady on the left was telling me about how she has been waiting about 6 months. She has a cavity that was left unfilled, and she was actually there at this point. Her tooth needed to be pulled. And it's not the worst thing in the world to lose a tooth. It's not even really the worst thing in this young woman's life, actually, at the moment. But she's a pretty young woman, and she's losing a tooth that she doesn't have to lose. And I'm thinking, we're spending $2.9 trillion in our medical economy, and we can't help people keep their teeth. That is such a profound failure in the basic blocking and tackling of what we have to do for everyday people. And we have failed in that regard. And there's actually a study, Florida dental study, found that people below the poverty line over a defined period of time lost 4 times as many teeth as people of middle income. And it is so frustrating that this very basic, not particularly expensive problem cannot be dealt with. I commend anyone here just to go to any hospital, go to any emergency room, and just look who's in the waiting room and how many of them are there for a tooth problem that could have been resolved in some other way. I should say that this is a tough time for those of us that are arguing how great health reform is. This is me preparing for yet another talk on health reform around the time that the healthcare.gov site had collapsed. So I should say, by the way, in the dental care that it is better for children than it is for adults. We have done a good job in Illinois with the kids in the dental area compared to for adults, but there's so many adults who are going to these bootleg dental clinics and so on. Doris, who was the young woman on the right, she said, I love my teeth, unfortunately this one has to go. I just waited too long, and I could have gotten it filled if I had been able to get help earlier, and now it's too late. Now, as far as the Affordable Care Act, one of the ironies in this is that things are actually going okay. Yeah, that's not the impression that you might get, but things aren't going too badly. And I think it's worth noting a few things about ACA. I think there's going to be a bunch of short-term political setbacks, and then we're all going to look up and say, hey, this thing's actually happening, and it's basically working. In that Ungapachki way that American policy moves forward, lurching forward and back. I bet you, was Ungapachki on your GRE test prep? A couple things that I want to point to. One is, I can't put on a slide, but which is true, is that we're actually seeing the beginning of bipartisanship on this thing. The fundamental reality of the Affordable Care Act is that it's the centerpiece of domestic policy achievement of Barack Obama. And you just can't get away from that until the day President Obama leaves office. And that makes it really hard for him, and it makes it really hard for a lot of Republicans who might want to work for him. An awful lot of Republicans who would love to do things in health policy that are boxed in by the incredibly poisonous environment. And I should say there's nothing really productive happening in Washington right now. And one of the reasons why an organization like Voices is so important is that all the really critical and worthy stuff is happening in states and localities right now. And that's also where so much of the success of health reform will be determined, is the quality of what we do in Springfield and the other capitals. But what we're seeing in the beginnings of bipartisanship is between the president and Republican governors. I mean, the typical House member has absolutely no incentive or really ability to govern well. They're not responsible for anything. It's different if you're a Republican governor. If you're John Kasich in Ohio, and you have to keep the doors open in your public hospitals, and you have hundreds of thousands of people who need health care. And both sides are kind of edging towards some sort of a dignified path so they can work together. And it's hard because these Republican governors have worked so hard to defeat the president politically. They signed on to Supreme Court briefs to try to have health reform deemed unconstitutional. They're worried about primary challengers. You can't just turn around on a dime and say, okay, now we're going to embrace Obamacare. And on the president's side, it's hard too, because he has to make some pretty tough compromises with Republicans. And it is, and I dislike actually some of the specific things that some of these governors want to do. They want to charge, for example, co-pays in the emergency department, which is my favorite policy. But I think in the long run, working together will bring some bipartisan legitimacy to this thing that it really needs. And certainly we've seen in Illinois where we have the lack of that, how hard it is to move forward. And it's not easy for Democrats who have to realize this isn't 2008 or 2009. It's a different political environment. And it's hard for Republicans who have to realize this isn't 2010 or 2011 either. And they lost a presidential election over this. And Democrats lost an off-year election over this. And we may lose another off-year election over this. So we all have to work together. But also, we're starting to see signs that the gears of the American health system are actually working better. And let me show you a few indicators of it. So we see various signs. Again, can you hear me over there? I'll come over to this side, so you'll have to listen here. But we're seeing various signs. One is a lot of people are signing up for the new marketplaces or for Medicaid. Up over 8 million are engaging the system, picking plans essentially after no one did in the first 2 months when healthcare.gov wasn't working. We're seeing millions of young adults signing up for their parents' plans. Now that's important for them economically because a lot of our adolescents in America now run to about age 38. condition, your parents' insurance for a lot of people is a lot better. And for instance, cancer patients who've been getting pediatric cancer care when they reach the age of adulthood, a real problem. And if you go and talk to people at Comer Hospital, they'll say it's really good for continuity of care to be able to keep those kids on the same insurance that they've had for their leukemia care up until age 18, because your health status doesn't magically change when you reach the age of majority. And about 3 million young people are insured who otherwise would have been uninsured from that group. And that's the most popular thing. One of the challenges Republicans have is all the specific elements like this are actually popular. And so you want to somehow, we're going to repeal this whole bill, which is basically socialist, but we're not going to touch all the stuff that you like. And it turns out all the stuff that you like is like a lot of what's there. So to rename everything, maybe we'll rename the exchanges the Ronald Reagan Freedom. Cost growth is down, and I'll show you some indicators of that. Premiums on the new marketplaces are below what we thought they would be 4 years ago. And also quality indicators are trending favorably. One of the striking things, which is not entirely due to ACA, but ACA exemplifies it, if you talk to people around town who run big healthcare organizations, they talk about healthcare differently. Say we have to move away from a fee-for-service model. We have to take into account quality. We have to take into account the psychosocial circumstances of our patients that affects their health. And we're going to be accountable for stuff in a new way. Here's some pretty striking data. This is just what's happening to medical care costs. You know, for the past 30 years, healthcare costs, 40 years, healthcare costs have absolutely been going up at such an unsustainable rate that it's deeply scary. In the federal budget and the state budget, so many of the red ink that you saw about Illinois reflected healthcare costs. And what's interesting is we don't know, but we may be entering an era where healthcare cost inflation is abating. Costs are not going to stop going up, but they seem to be going up at roughly the same rate as the overall economy for the first time in a very, very long time. And actually, if you look at annual per enrollee growth, so you can see this is, 2000 to 2007, 2007 to 10, and 10 to 13. We see a real decline in private insurance, the rate of growth of that. In Medicare, we see a real decline in that. Now, how sustainable this is, by the way, the scary part of the federal budget. Basically, the entire federal budget anxiety between now and, say, 2080. I don't know what's going to happen after 2080. It's all, that's a joke, by the way. It's Medicare. Everything else in the federal budget is very controllable. But if Medicare continues to rise the way it has since 1980, we will destroy the federal government. And so seeing Medicare costs come down is critical. When you look at Medicaid, per enrollee cost growth is negative. This is the most disciplined part of the entire American health system, is Medicaid. You often hear people say Medicare and Medicaid costs are out of control. And I'm thinking, like, are you talking about America? Or is there some other place that has two programs called Medicaid that I just don't know about? Medicaid costs have gone up a lot because the number of people who need Medicaid has gone up a lot. But the program itself is certainly not out of control as a financial matter. Okay. Here's, by the way these changing projections affect the way the Congressional Budget Office, which is the umpire of the federal budget, the way they think Medicare and Medicaid costs are going to go up over time. So this is projecting out to over the next decade. Here's what they were predicting in August 2010, where the y-axis is the percent of the economy these programs will take. And you see that since 2010, they have really lowered their projections of how much Medicare and Medicaid are going to cost. And the Affordable Care Act is going to cost much less than anybody predicted, but including me, because healthcare costs have moderated. And that's going to make it cheaper for people to buy insurance, and it's going to make it cheaper for the federal government to provide that. That's not all due to ACA itself, but ACA has helped. And that's a tremendous change in the landscape. So this is, if David made you really depressed about the Illinois budget, which I think is pretty appropriate. I think probably major depression in this. You do not satisfy the criteria for major depression because you just had a tangible grief event. So, but it also goes beyond that to quality. So, for example, here is a measure of avoidable readmissions. So this is monthly 30-day readmissions in Medicare. And you see that around 2011, it's really gone down. And I can put up a very similar chart for hospital infection. Our healthcare system is getting better in a striking way, and ACA has contributed to that, because I think everyone involved knows that people are going to be held accountable for this in a different way. Let me say a few things about young people. And I'm sorry that I keep moving away from the mic. I know that may be annoying to folks. One of the things that we see is about 8 million people. 8 million young people will have access to health insurance through their parents, and as I mentioned, about 3 million of those people would have otherwise been uninsured. It's interesting, we're reducing the rate of uninsured indirectly right now through ACA. I'll show you a graph that shows the rate of the uninsured is coming down. It's not that we are actually scooping up the uninsured and enrolling them yet. That hasn't really happened yet in big numbers. What's happening is a lot of people who would have become uninsured are now staying insured through various pathways. And one is all of these young people who otherwise would become insured who are still on their parents' insurance. And so if you look, for example, among those 19 to 25, and you look at the rate of uninsurance, it was kind of creeping up right up until the point that ACA kicked in. And then all of a sudden you see it start to drop. And if you look actually at 26 to 34-year-olds, which I don't have on this graph, it continued to creep up in that older group that was not eligible for that same benefit. And also, young people are eligible for a lot of financial support. One of the most important things ACA does is it's a very large financial subsidy to working class people and to young people. And we don't always think about it that way, but that's really what it is. About 82% of the young people will be eligible for subsidies either through Medicaid or through the new marketplaces in health insurance reform. And one of the things that we see is as the rate of uninsurance goes down among young people, it's really concentrated in the group of young people who have modest incomes, which is really the people that we should be helping. And so if you look at the rate of uninsurance, if you just compare 2011 to 2013, and you see that the proportion of people who've been uninsured in the past year is 70% down to 59%. And I can tell you that's a lot of my students. I always begin the year, I ask my students, who are the uninsured? And they say, you're tired, you're poor, you're huddled masses turning to breathe free. And then I say, how many of you were uninsured this summer? And like half of them raise their hand. And one of the scary things is how many of them think, well, if I get hit by a car, I can always sign up for Obamacare, or they'll take care of me in Stroger, and they have to take care of me for free in the emergency room. They do have to take care of you in the emergency room, by the way. But that word "for free," that doesn't count. There's nothing there for that. The hospital has every right to send you a bill. And they're not always too nice about it. So if you look just at the latest enrollment statistics, you see we're getting up near 10 million people who are signing up for exchanges, who are on Medicaid, and so it's moving forward. And particularly in the past couple of months, it's moved forward pretty well. It can be a lot better, but it's moving forward pretty well. And a humbling experience because of some of the failures that we've seen, but it's happening. Okay. So if you look at just the graph over time of marketplace enrollment, there's virtually nothing for the past 2 months, but for the first 2 months, and then you see it starts to come up. If you look at the percentage uninsured, this is a Gallup poll. We're starting to see, as you can see in there, starting to come down. We now have the fewest percentage of uninsured people since about 2009, and I think that's going to continue to come down. And it's going to take a while, but we're going to continually chip away at it. And I think that we're going to discover in a gradual, continuous way, hey, there's just fewer uninsured people around. And there's more uninsured people that we now have a way to help than was true before. We also see that the age mix of people coming into the marketplaces, there's a real concern that the early people who sign up for healthcare are the people who really know that they need it. You know, imagine that the website is really, really difficult to use and people have heard all sorts of bad things about it, it's a pain. Who's going to really take the time to make sure that they get themselves enrolled? It's people who have a health problem. So initially, a lot of the people signing up were pretty sick. But what we're seeing is that that's really starting to change. About 27% of the people signing up are in this young group. They'd like it to be about 35%. So it's not optimal, but the mix is good enough for the insurance companies to basically feel like this is going okay. One of the key things to watch for you is, you know, in a very partisan environment, you want to get a sense of what's that number that would actually tell me something real. What are the premiums going to be that are offered for 2015? We're going to know about a month and a half. We're going to start knowing what are the insurance companies going to feel comfortable charging for the next year. And I think it's going to be, you know, reasonable. And it will certainly be below what anybody would have expected in 2010. So these are all good things. Now, I should say, I won't say a lot about this, but if it comes up in the questions, I'd be happy to talk about it. There's a lot of stuff in health reform which I refer to as the junk DNA of the bill. Has anybody read the health reform bill? Come on. It's 906 pages. It looks really long because they padded the margin and they used big print. It's like an undergraduate trying to make it look like it's one of the talking points going around was the Senate bill was actually shorter than Sarah Palin's memoirs. There's a lot that's in there that's actually really important, and particularly for those of us interested in disability. There's a lot that's really important to try to help people live in their communities in a better way. And so we can certainly talk about it, especially in Illinois, which has had a real bias towards institutional care. There's a lot in the Affordable Care Act that the state is now taking advantage of to try to improve community-based care, and also to improve, by the way, the state budget. The state's going to get about $90 million from a bunch of these provisions that relate to disability that the state really needs. And I think in a day-to-day basis, we're going to see a real improvement in the lives of a lot of disabled people in Illinois as the quality of services improves. Now, let me skip up a little bit, because there were some questions before I started talking. Someone said, how about mental health? And let me say a few things about that. I should say, by the way, I'll show you my favorite graph of Illinois. You might say, well, it's really nice for those disabled people or dual-eligible Medicare, Medicaid people that programs are improving, but what does this have to do with the Illinois budget and what's really going on for most people? The fundamental fact you have to understand about Illinois services is the typical person receiving services is basically pretty healthy, but the typical dollar is going to a person who's pretty sick. And so if you want to save money, you have to somehow deal with the people who have costly and complex challenges. So for example, in Medicaid, we often hear, we should really be tougher on the people who are kind of the marginal Medicaid recipient. Maybe make them come in and bring a shoebox full of forms before they can enroll. So the bottom 72% of Illinois Medicaid recipients account for a total of 10% of all the Medicaid spending in the state. There's all kinds of issues about, are we helping those kids in the best way? Can they get to the dentist's office? All that kind of stuff. In terms of the money, we could absolutely cut off 3/4 of the people from Medicaid in Illinois, and we would save a maximum of about 10% of our Medicaid budget this year. The top 3.2% of Illinois Medicaid recipients account for half of the spending. The top 3.2% account for half of the spending. And so that is the group of people that you really have to engage when you're really talking about the economic issues that are fundamental. This is just an amazing graph. That's just the distribution of spending, where the blue graph is the cumulative cost, and the red is the average spending per person in those little categories. And you can't even see anybody basically up until about the 80th percentile on the scales that I've drawn. So like all these people, these are essentially
98% of the kids in Illinois on Medicaid are basically all like over here. Okay. So that's a sort of a fundamental fact. Now, so we have to somehow pay greater attention to those people. And one of the striking things, again, getting back to David's graph, a lot of those really costly, complex people have great access to medical services, and they have terrible access to social services that actually are critical for their medical care and their health status. I mean, it's really striking how much, in some ways, it's easier to get $500,000 for a liver transplant than it is to get a housing voucher. And that's a really striking thing when you consider that housing for a year costs about $9,000 for one person, and a hospital stay is like $20,000. So another interview that I did for my one blog is I went and I looked at some folks who are enrolled in Medicaid-supported housing. One of the interesting experiments that people are doing is they're saying, let's look at some of the frequent flyers. So this gentleman is living with HIV and has a series of other health problems, and he's one of those people that's spending $200,000 or $300,000 a year in healthcare costs. So they put him in a modest apartment where he has a refrigerator where he can keep his medications, where he's in a more positive social environment, which helped him stabilize some of his issues like substance abuse that he had. Is it transformational? No, but he's healthier and he's not in as acute a need as he was before. Total cost of the housing, $9,000 per year. Another young woman on the right here, same story. So she's in a modest apartment, vast improvement in her health status by dealing with the psychosocial dimension of her challenges. And if we cut programs that deal with people's social needs, I can guarantee you that creates a much bigger burden on the healthcare system for the people that are the most expensive and challenging for all of our healthcare providers to deal with. And that's something that we have to think about. And one of the things that I think we have to think about also is the lack of cash assistance for many children who live with a variety of challenges. So, most kids with disabilities are not SSI recipients. They're not official participants in disability programs. If they get cash assistance, they get it because their parents are poor. And so what's happened during the Great Recession is a lot of these kids have lost benefits just because of the recession and because our public assistance hasn't kept pace with it. So this is the worst. This is like the worst slide ever made. So let me take a moment to explain it. The dotted line in green the line in green is the number of kids in poverty. Newsflash, it really went up during the Great Recession. And the dotted line represents the percentage of poor kids who are getting cash assistance. And I should tell you that I was kind of supportive of welfare reform in 1996. I wasn't happy about it, but I thought, I looked at the way it played out and I thought, this isn't so bad. Now I think, well, it is actually so bad. Because what's happened is, here's the percentage of kids on AFDC are now TANF, Temporary Assistance for Needy Families. That percentage just plummeted. The caseload in absolute numbers basically stayed level while the number of poor kids exploded. And how many of you have heard stories about kids, larger numbers of kids getting disability, maybe some scandals with parents coaching kids to get onto disability programs, things like that? We see listen to the NPR program Trends with Benefits. Great title, by the way. It's not a great show, but great title. Kids on SSI, which was always a very small number, stays basically completely constant. So what we see is the percentage of kids who can get help has really gone down. At least to get cash assistance. Now in Illinois, these kids are still getting health insurance, but they're not getting a lot of other things that they need. And one of the things that we have to think about as health reform rolls out is, how can we deal with this problem? And one way to deal with this problem is, I think that we have to think more imaginatively about Medicaid. You look at a state like Kentucky. Somebody here from Kentucky? interesting state. It's done a beautiful job implementing the Affordable Care Act. One of the sad commentaries in America, by the way, is the politics of ACA are different in Kentucky because so many of the poor people benefiting are white. And the best predictor of a state not expanding its Medicaid program is the percentage of poor people who are non-white. And that's just there's a politics of impunity there that is very sober. But in Kentucky, by the time ACA is fully implemented, I mean right now, about 30% of the non-elderly population in Kentucky are going to be Medicaid recipients. And the same thing is true in a lot of neighborhoods of Chicago, where we look and we see, boy, between Medicaid and the new exchanges, a huge percentage of the population is going to be in these health insurance programs. And so then we have to ask the question, are we using these programs to their best advantage? You know, if all the kids are on CHIP and Medicaid, it becomes a really key interest for CHIP and Medicaid to wonder, you know, what are they eating in the high school cafeteria? Do they have access to exercise? Who is dealing with them about smoking, tobacco control, and population health? And I think we have to think more broadly about population health within these programs because Medicaid is the only thing that's going to be fiscally protected in the financial environment that we're in Illinois and many other states. I mean, the one thing that will not have a sharp downward red bar on that list that David shows is going to be Medicaid. I mean, Illinois and other states, they're not going to want to cut Medicaid because that federal match is so critical. And so how can we use Medicaid in a more imaginative and more public health conscious way? It seems to me to be a major opportunity in public policy that we're missing. And I hope we can do better. Let me just show you, I've gone on a long time, so I'm just going to show you some mental health things, and then I'll stop. And I'll walk you through. Actually, I'll walk you through these, and then I'll do some mental health issues. So, health reform affects many different people in many different ways. Helps some people and not others. It's worth thinking about these 5 different people, 5 different situations to think who's going to be helped by ACA and not. How about this top person? How is that person helped or not helped by health reform? Anybody have a thought? I'm talking a lot here.
They get on Medicaid.
Now, why is it different now?
Well, they weren't on Medicaid without an adult or a child before. They couldn't get on CHIP.
So excellent. So that person, they get on Medicaid, and also, as I'll show you in a minute, the essential health benefit and the package within Medicaid and actually within private insurance has to cover mental health and substance abuse services. And that's critically important. How about the second person? Sorry, by moving around, am I causing chaos? I don't want to be a talk show host. How about that second person?
Lost their job
Yeah? So how would a health reform help them?
because the health care is not attached to the job.
So the health care is not attached to their job, and they can't be discriminated against on the basis of a pre-existing condition, and they can get a subsidy. By the way, the one thing ACA will not do for them is help them get another job, which might be nice.
Also, if this work is going to go on SSDI, there's a 2-year waiting period to get American.
So the waiting period around SSDI, about many of the people that I've met who've gone medically bankrupt or are close, ironically were already determined to be eligible for SSDI, and they were bleeding because they had this really serious illness while they were waiting for Medicare to kick in. And hopefully we can make that a thing of the past in ACA. How about Rocky Clark? Anybody see the coverage of him? He's a local football hero in Chicago. Became a quadriplegic on the gridiron. I could give another talk about football. But how about him?
No lifetime limits on benefits.
The lifetime cap. So what happened to him? What happened to him was he was getting all sorts of home health care and all sorts of help from the insurance that was provided through Eisenhower High School in Blue Island, and then he hit the lifetime cap, and a lot of those services went away. And I'll mention in a moment what happened to him after that. How about Marcella Wagner? She's a pregnant woman, uninsured. She had insurance for her baby through Medi-Cal. She got into a car wreck and was left quadriplegic. Sadly, it turns out ACA does not help her as much as it should, because she ended up on SSI, and to get the care that she needed, she can never have more than $3,000 in the bank for the rest of her life. She can't have a college account for her child. She can't save for her retirement. Her husband can't work more than part-time because he'll exceed the income limit that makes that family eligible for SSI. And ACA has failed to deal with that family situation in the way it needs to. How about this last one? A family with private health insurance but has a child in a wheelchair with cerebral palsy or some other serious challenge. Any thoughts on that one? Yeah?
When the child turns 19, they can stay on family's plan. There's no annual limits, there's no...
So they benefit from that. I will put other hands up. No, so that child benefits from all the pre-existing condition stuff. No one actually knows how well the health insurance exchanges are really going to work well for this family. One of the challenges, I must say, having dealt with the Medicaid system, despite all of its problems, if someone said to me, hey, you could take your brother-in-law out of this Medicaid that everybody says bad things about and put him into this health insurance exchange and get a silver plan for him, I would sort of think, maybe next year. Maybe come back to me and talk to me in a while. Because we really don't know whether the actual practicalities of insurance are going to work for this family yet. And I think we're going to see a lot of bumps in the road for these children with special health care needs, while that just no one's focused on yet because everyone's focused on other stuff.
And there's no long-term care coverage of private insurance.
Yeah, the long-term care issue has been left unattended. So here's just a summary of some of those points. So, and this point that you made about putting people on Medicaid just because they're poor is just so important. And it's so important for a lot of the parents of the kids that we care about. One of the things in America, we love to help kids, but we're so ambivalent about helping their parents. And since the kids and the parents kind of go together a lot of the time, that creates a tension. So here's a man who's looking for help. He's begging motorists, and he's got 2 kids. And he's not a mom eligible for welfare. He's not. He doesn't have a federal disability. He's not a vet. And now he doesn't have to fit a category. Let me say some things about mental health, and I'll stop. Does anyone need to stand up and do some Tai Chi or anything? Are we okay? So many adolescents and young adults have mental health or substance abuse problems. And by many, here's what the world looks like. So if you look at this is just simple data from the U.S. population. It's survey data. And we see about 6.3 million Americans have a substance abuse disorder, and they're either uninsured or they have insurance that doesn't cover substance use disorders, which is really a striking thing. And of that, the majority of these people, about 3.5 million of them, have incomes that are below 200% of the poverty line. So this is the pre-health reform world. And if you look at who are these guys, it's basically young men with alcohol disorders. Larry mentioned that I'm the co-director of the University of Chicago Crime Lab. These are our customers. These are the people cycling through Cook County Jail because they get into a fight. They also are great customers for the morgue. I did an epidemiological study of adolescent boys and young men who've been murdered. And 1/3 of the people had high blood alcohol level at death. So if you say, how do we deal with our violence problems, helping people with alcohol disorders is pretty fundamental to that. So when you break it down, these are 70% male, alcohol disorders is the ballgame for a lot of people with substance use disorders who are uninsured. But it's not a particularly minority population. Non-Hispanic whites would be the majority, but people who've been left uninsured. But now comes the Affordable Care Act. I aim for subtle. And so what we see is there's several aspects of ACA that are directly pertinent to this issue. One is that there's mental health parity. So in 2008, by the way, George W. Bush was very good on substance abuse and mental health issues in a lot of ways. He wasn't my favorite president in various ways, but he was, when they bailed out the banks in 2008, they also included in that same bill a parity, mental health parity. And he was supportive of that, and many Republicans who actually opposed ACA favored the mental health and substance abuse provisions. Again, everyone has a cousin or a brother. This is not the culture wars of 1992 anymore about substance abuse. And it turns out that a lot of these folks can get into Medicaid, but also they are entitled to a strong package of mental health and substance abuse services that actually are important for people. So, and it turns out once, when the Messiah comes and all the states pick up Medicaid expansion, which I think will be in about 6-7 years, about 62.5 million Americans will have mental health and substance use coverage that they don't have right now. And that's going to be transformational. I should say that it's going to be transformational, but it's also going to be a really painful adjustment. And if you look at social service providers around Chicago, you will see many of the ways that it is a painful adjustment. Medicaid will become the dominant player in all of these services. If you are providing mental health and substance abuse services and you don't take Medicaid right now, either you will or you will somehow change in some drastic way. And many of these organizations are terrified of that. They don't have an IT system to bill Medicaid, they don't have a doctor on staff to do the stuff you have to do to qualify for Medicaid, and so on. And we'll also have to figure out, in some ways, Medicaid has to raise its game, because it is attended to public health. Now, the long-term residential services are still going to be a problem. How does Medicaid pay for long-term psychiatric care?
Pays a lot.
It pays a lot, but officially it does not pay for, there's something called the IMD exclusion. Does anyone know what the IMD exclusion is? Someone want to tell me what the IMD exclusion is? Yeah?
Medicaid cannot pay for any institutional facility more than 16 beds, and over 50% of their patients will be treated primarily with mental health.
Perfect.
We can't hear over
So
here.
what was just said, what's your name?
Katie
So what Katie, and you left the last name?
Hinshaw.
Katie Hinshaw just said that if you have a facility that has more than 16 beds, and the majority of the patients are there for mental health or psychiatric disorders, Medicaid will not pay for an inpatient stay there. That's the IMD exclusion. How many of you are trying to help young people with psychiatric disorders and you're like, this is a problem? Now what Illinois has tried to do to deal with this is, we'll just use nursing homes. By the way, this has been a fantastic policy for the legal profession in Illinois. Because that is certainly, but it's a genuine challenge that we haven't dealt with fully. So let me, this is Rocky Clark, and what a sad case. He hit the lifetime limit, and his mom basically tried to take care of him without all those extra supports. He actually died not long after he hit that lifetime cap. And one of the things that's really important about stories like this is to understand, this stuff is there's a lot of numbers and graphs and stuff. There's actually human beings here who die when they don't have their needs taken care of. And that's a real thing. And he's a real person. And we don't know for sure that he died because he had this insurance problem, but it did help him. I'll skip up ahead to, by the way, one of the aspects of Marcella Wagner's stories, it's so insane that she has this $3,000 limit that I think it will be politically generative, and I think there'll be pressure to change this policy. But let me just close by saying we have a lot to be proud of in health reform. A lot of good stuff is happening. And don't be discouraged. I think optimism is a really important quality in public policy. We also have to be vigilant in understanding where this act is going to fall short. And as we saw with the website, it's going to be a bunch of stuff screwed up. And that is, it's not our job, as I always speak as an advocate for services for needy people, it's not our job to say health reform is perfect and to give it the Cisco and Ebert thumbs up assessment. There's going to be a lot that's not going to be thumbs up. I love health reform, but that country music song, I don't like half the people I love? That gets instant recognition. That's kind of the way I feel about a lot of stuff in health reform. So let's keep our heads up. Let's fix the things that are broken. And but walk around with a smile on our face, knowing that there's a lot of good stuff happening, and that we can feel good about so much, that in part because of the activities of the people in this room. So with that, I'll stop and thank you very much.
We're watching our clock. Harold will take a couple of questions. Are there questions in the room?
Yes. Thank you, Dr. Pollack. Yes, so great. I'm Susan Gordon from Bird Children's. I appreciate that you said what you did about children with special needs, and much remains to be said about them. Because in as much as the ACA is so great in terms of pre-existing conditions, being on the parents' insurance, really children represent such a small fraction of who's benefited from the ACA, except for their parents being covered, which is fabulous. I wonder if you have anything to say about the Children's Health Insurance Program, because some people think that ACA means that can go away, and the Children's Hospital Association really is working hard to keep that in place and to think of new models of care for these fragile children. So interested in what you have to say about that.
I would like to see the CHIP program stick around. I think CHIP plays a vital role, and they figured out how to do things within CHIP that people have not figured out how to do yet in the new exchanges, for example. And so there are parents who have private insurance who are using the CHIP program to help kids with special needs. CHIP has a benefit package that works. People who are at Children's Hospital know how to work with the CHIP people to get people what they need. And I'd like to see CHIP renewed. It's up for reauthorization. I'd like to see it renewed. And I'm actually kind of conservative when it comes to making radical changes right now in Medicaid and CHIP, till we see if children with special health care needs don't need CHIP, and we have lots of other ways that are working really effectively without it, then maybe at some point we can phase CHIP out, or in some way, but we're not at that point yet. And I think the good thing is that I think policymakers are very averse at screwing up something that involves children with special health care needs. This is, if I'm a legislator in Springfield, the idea of a kid in a wheelchair coming into my hearing room with this very angry mom showing up next to him, that is deeply terrifying. And that's true in Washington as well. So that's my 30-second response.
Thank you. Any other?
Yeah, a lot of criticism on the exchanges has been that people who have coverage are getting better coverage now. And that percentage is changing now. It's more the uninsured, but still it's a minority. So only 27% of people who go through exchanges were uninsured previously. But there were like 25 to 35 million people who are underinsured, and the Commonwealth Fund follows that. Could you address that issue? Because that seems to be a benefit to the healthcare system and to productivity and health that is being criticized because people don't recognize how deeply the underinsurance issue had grown.
A couple of things. So the underinsurance issue. A couple of things to say about that. One is, we have 320 million people in America, and there are winners and losers from the Affordable Care Act. And there are some people who are now being forced to buy a richer insurance package than they want. Or they're being forced to be in an insurance pool with sicker people than they were in before. You know, if you're in an insurance policy that really keeps out the sick people, if you're the healthy person, you know, that's kind of fun, because you get to pay a lower premium. Now, what happens to you if you get sick is another question. But many of these people who are either underinsured or at least have a pretty Spartan package have no way to really recognize that until they get sick. And so politically, there's way more people who are healthy than who are sick. And so I think it's going to be, there are going to be a lot of cranky people, particularly because the people that are, a lot of the losers in this are relatively healthy people and also relatively affluent people who are not eligible for subsidies under the exchange rate. And who are the people that really make American politics happen? It's basically relatively healthy, relatively affluent people. So the fact that 5 million people can't get Medicaid in red states gets less attention than the fact that maybe half that number of people are having to pay higher premiums in a way that is genuinely that they don't like. I will say most of the real horror stories about people having to pay a lot more tend to implode when you really look into them. But there are people who pay more. It's part of it.
So I want to thank you, Harold, very much